Okay. I'm going to start off just asking for any of the three of you how you see, I think as we sit here in this room at Duke and in the United States, we often think about partnering and improving health through our own inventions and going out and collaborating with people in Nepal or with one country. How can you see that countries can start working with and learning from each other? Say Nepal and Kenya, or Kenya and Uganda, or how do we get countries to work together also, and are there lessons to be learned there?
I'm happy to take a first stab at it. So we're already doing that, and I recommend during any of the breaks to come talk to Suraj, I mentioned earlier. So we're part of a consortium called PRIME, or Program for Improving Mental Health Care. And this is across 5 countries, South Africa, India, Uganda, and Ethiopia. And the idea is, what are common solutions in settings that have almost no mental health services? The idea being that a North-South partnership alone is not going to generate the innovation needed to really address these problems. There may be cultural differences, but there are very common infrastructure limitations, which mean the solutions, if just generated in one country, may not be generalizable. But we are finding solutions, ways to detect mental health problems that has not previously been used, and way to treat mental health problems that are working across these 5 countries. So I think these types of consortiums are absolutely crucial to find generalizable, major, impactful solutions.
I totally agree with you, actually. Some of the countries with similar situations, they could learn each other's. For example, China and Vietnam, when they started to reform the public hospitals, and they face more or less the same problem and challenges. So China's lessons could be well applied to the Vietnamese context. For example, the Chinese government tried to increase the autonomy of public hospital, leading to a profit-driven situations. So Vietnam has done more or less the same, just 5 or 10 years later. So how Chinese government could reform public hospital in effective ways could offer tremendous lessons and experiences to Vietnamese.
Maybe I would just add, since we are at a university, I do think universities could play a particularly important role here, right? So knowledge generation is kind of at the core of what we do, and perhaps we're not always as good at the knowledge sharing and dissemination and lessons learned piece. And I think we have a responsibility to develop, to create knowledge platforms, if you like, learning platforms. And there are some good models out there. Perhaps the joint learning platform for universal health coverage, where countries are learning about pathways to universal health coverage, what's working, what's not working, is something that we could build on.
Yes. We have a microphone over here. Oh, Bill? Yes. Well, let's go with Bill, and then we'll get your question. Yeah.
Thank you. All right, thanks, everyone. Thanks for the talks. They were great. I had a question mostly for Gavin, but it builds off what Brandon's talking about. So the environment has a big impact on health. The Center for Health Impact, I'm curious to know what your perspective is on how environmental solutions are going to be integrated into them.
That's a great question. So, and a very, very valid point. So, when we published Global Health 2035, and we did a bit of a world roadshow to roll it out, the question you just raised was, I think, the most common question we received. Why have you focused so much on the health sector? There are all these other sectors that clearly have a massive impact on health, and we know that, and we know particularly that social determinants make a very large difference. Education of girls, for example, water and sanitation, and that there are clearly public policies that are outside of the health sector that make a very big difference. On the other hand, I also think that part of the reason behind this report was that it was all too common for us to be at development meetings and hear, you know what, you folks in the health world, you had a great decade, right? 2000 to 2010, aid tripled, and there was all this attention, and there was the Global Fund that was launched, to tackle AIDS, TB, malaria. There was Gavi, the Vaccine Alliance. You had a great decade, and you guys, it's over for you. Health is over. Health has been done, and it's time for us in the development world to move on to sectors that matter: climate, environment, and so on. And it's not a zero-sum game, and it's appalling for sectors to be battling for resources. There are plenty of resources out there. But we found that really deeply disturbing and deeply worrying. And we did consciously and actively want to refocus our attention on the health sector, which has drifted towards the bottom of the development agenda, to remind folks that health is the mother of all development sectors. And that actually, if you look at the data, it's totally true that social determinants matter, but it's incredibly striking how health interventions, life-saving health interventions, to keep people alive matter particularly. And so it was partly a conscious decision. We do talk about these other factors in the report. I've been involved in disease control priorities, the third volume of this compendium of global health interventions, on a whole chapter devoted to sectors outside of health and how important they are, and trying to find the most effective and evidence-based, taxing tobacco, for example, motorbike helmets, clean water. So there is a broader recognition as well.
Yes, thank you. Mike Landry, I'm the Division Chief for Physical Therapy here at Duke, and thank you to all three of you. And I want to take 2 seconds to personally thank Mike Merson for all that he's done in 10 years. So thanks, Mike. I just wanted to make a point, maybe it's more towards you, Gavin, but you know, we've done well, as you've mentioned, to preserve lives around the world. We're not there yet. But we are now starting to see another convergence, or divergence rather, in terms of people with disabilities. So it's one thing to preserve life. It's yet another to think about quality of life among those who we are currently around the world saving. So maybe just your comment of where your report and maybe how we can move forward from that perspective.
No, it's a very good point. We did focus on survival. We did focus on maternal mortality, child mortality, infectious disease mortality. But with the reduction in child deaths, there is obviously now, for example, an adolescent bulge we're seeing in low and middle income countries, an expansion of the proportion of the population who are adolescents. That itself comes with a whole host of issues that are around wellness, around risk behaviors, around HIV, around non-communicable disease risk factors. And of course, we're seeing aging populations, particularly in middle-income countries, putting very large strains on social sector spending. So yes, absolutely, that is part of the puzzle. That is not what this specific report was about. But again, in disease control priorities, there's a whole host of chapters looking very much at wellness and at thriving. There's this terrible term, thrival, that I've heard, that combines survival and thriving. So we are absolutely entering into an era of thrival. And just a shout out to physical therapists. My sister's a physical therapist in London. And she was on the Ebola response team that looked after the Ebola patients at Royal Free Hospital in London. So yay for physical therapists.
And let me ask one more question. As I travel around the world, one of the things that I see, including in North Carolina, is that as health improves, for many people, it seems to get almost worse for others who are left behind. Do you see a way that we can move forward where there is more equity as countries and communities become more healthy?
Yeah, I would say from the mental health standpoint, this is a huge problem where we have actually decent psychiatric services in many even low-income countries, but they are so limited to specific resources. And you mentioned before, the vast majority of the improvement in maternal and child health comes from these public health measures, not from adding more doctors. And the problems we see in mental health is more psychiatrists goes to a very limited subset of the population. And so I think it's rethinking the entire medical structure about what ultimately achieves the biggest delivery. And so we found that a lot of that are task sharing and task shifting approaches that actually get at the whole community more broadly. And so you have to put money in to make that happen, though. This huge disparity where it's worth paying a doctor to do this, but you have somebody who's a community health worker doing almost the same thing. Oh, but we're not going to pay you because you're just helping your neighbor out of your goodwill. That is a major problem that I see that's going to be a barrier as we try to promote effective task-sharing interventions going forward.
Very good.
I think we should take a really comprehensive approach to addressing these kind of problems. What you actually point out is exactly correct. For example, the average life expectancy in Shanghai, Beijing increased much more than the life expectancies in Guizhou or in Tibet, in the poorest area of China. So the gap has actually expanding, not narrowing down. There are lots of reasons behind that. Obviously, economic reasons, the living standard, but also environment. Actually, now more and more factories move to the western part of China because of lower labor costs. Results lots of cancers, other diseases in these regions. So when we talk about improved health, in reduced health disparities, we not only just to focus on healthcare, but also other issues, other social determinant issues.
Kate, I think it's the defining problem of our time.
Yeah.
And that is that 70% of the world's poor are now in middle-income countries, not in poor countries. And these are countries who the international community have said are, quote unquote, too rich now to qualify for aid. They've been cut off. It's called the middle-income dilemma, or the missing middle problem. And these are countries like China, like India, with huge populations living in poverty and high mortality. And we haven't, I think, as an international community, really got our heads around this missing middle dilemma. 70% of the world's TB, 60% of the world's HIV, 50% of the world's malaria. That's in middle-income countries who we're sort of walking away from now. And sometimes the governments themselves, they're not fully set up to reach these populations. They don't necessarily have the financial resources, the tax base, or frankly, at times, these are marginalized populations who they politically don't have an interest in reaching. Men who have sex with men, intravenous drug users, transgender people, women, children, scheduled castes. It's a massive problem. And I think it's going to be one of the defining problems of the next generation for global health.
Thank you. Thank you. I think there's one more question, and then we'll...
Yeah, my name is Pap Guy. I'm with IntraHealth International. Actually, I have a couple of questions, one for Brandon and then one for Gavin. For Brandon, thank you for sharing the concept of science and service, integrating science and service. I'd like your comment on how do you impart this, especially in resource-poor area where some other consideration. So how do you make sure you ensure that your collaborators in the field also embrace this? And for Gavin, it's on the grand convergence, given how much we're counting on domestic mobilization, how sure are you that we're going to receive that? And what if we don't get the right domestic mobilization? Thank you.
Pap, thanks for the great question, and it builds on this concern that I just raised about task sharing and task shifting. Is in some ways the science and service issue in a resource poor setting can be taken too far. And we've seen development consultants come in and say, in Nepal, actually, you shouldn't pay a female community health volunteer. Because when she goes out and she does this work, it's good for her karma. It's good for her family, right? That this is a good thing that's going to help her and her community in general. If you pay, you're going to take away from that religious and social benefit she has. Thank you, male government health officer who's getting paid for everything that you're doing.
And
right?
great
What's happening to your karma? So I think when we raise this, we can't use it as an excuse not to compensate people for what they're doing. We have to use it to be able to support why this is important for everyone, that everybody needs to be a part of this process, and increasingly trying to say, this is good for your health. There are benefits to you, whether it's religious or it's genomic activation. There are good things for you about doing this, so that across the board, how is everybody equally investing with the emotional content, with the dedication to that process? And the trick that we've used that's transforming things is service user and patient involvement. Having people that are the beneficiaries of these programs come, share the benefits they've had, share how it's impacted their lives, and then work alongside the community health worker, the primary care worker. That changes the whole dynamic. And so I think globally, as health systems restructure, more and more patient and end user involvement is crucial across all health fields.
Pap, it's a great question. A few points. Firstly, I think that we in the international health community, we have a responsibility to continue to make the case for global health aid. So yes, we had this fantastic decade where aid tripled. It's been stagnant for the last 5 years. It's a new normal. And if it hadn't stagnated, there would have been an extra $38 billion. But we shouldn't accept that new normal. We need to continue to make the scientific case, the evidence-based case, because health aid has actually been spectacularly successful. Even aid skeptics like Angus Deaton, the recent Nobel laureate in economics, even Deaton recognizes that health aid has been extraordinarily successful. So let's not give up on that. Secondly, it's a question that to some extent is empirically testable, and that I hope that the Centre for Policy Impacting Global Health, with its partnership with the Public Finance Group in Duke Centre for International Development, will be able to empirically test. This group has been in a number of lower middle income countries for 30, 40 years. They know all the players. They work very closely with government officials and think tanks. But they haven't specifically worked in the health sector before. They're cross-sectoral. So it's going to be interesting to see whether their kind of public financial management approach works. And the third thing I would say is there are countries that have done it. China lifted 700 million people out of extreme poverty, and it achieved the fastest expansion in universal health coverage ever recorded in human history. So we need to learn from, a political economy point of view. What is it? What made China do it while other countries have actually cut their health spending? What are the drivers? What are the barriers? What are the stories we can tell the finance minister? Because she's the one with the most power. Is it, look at the returns that you get? I mean, is it an economic case? Is it a childhood development case? Is it a vote case? Is it that, the populace are going to vote for you because they love it? We need to find the right stories, I think, to tell the finance minister.
All right. We're going to stop here. Thank you so much to our panelists. Thank you for your questions.